So I'm Michael Atkins from the Georgetown Lombardi Comprehensive Cancer Center, and I'm here with Maria Carlo from Memorial Sloan Kettering, and we're going to chair this interesting session on biomarkers. And the first talk is actually a tag team talk from a great duo that's contributed a lot to a lot of areas of kidney cancer research. Toni Choueiri and Sabina Signoretti from the Dana-Farber Harvard Cancer Center, Dana-Farber Cancer Institute, and Brigham and Women's Hospital. Tony's a medical oncologist who's head of the Link Center for GU Oncology at the DFCI, and Sabina is a pathologist who is helpful to all the people at the Dana-Farber Harvard Cancer Center, and is a pathologist for the kidney cancer spore, which has been in existence since 2002. Tony, go ahead.
Actually,
do you want to use
I
that?
have mine. Can you hear me? Okay, good. So thank you, and I'm glad all the stars lined up here at this meeting. Consider this your meeting, the first basic science meeting to kidney cancer. I'm glad two of my former and still current mentor, Mike Atkins and Bill Kalin, are here. So pleasure to talk to you about biomarker for checkpoint blocker in the second line setting from Checkmate 025. And again, this meeting is largely based on an RFA that kicked off all these grants from the Department of Defense. And I'm going to show you the protocol, the research that was actually funded. These are my disclosure for 2019. Actually, they're not updated. I am going to update that I am the co-chair of this meeting as a disclosure. So I disclose everything. This is the award with my co-partner, Sabina Signoretti, that was recommended for funding based on Checkmate 025. For the non-clinician in the room, this was a phase 3 trial that established the first checkpoint inhibitor in RCC that pit Nivolumab against everolimus in patients that progressed on VEGF target therapy, showing an overall survival benefit of 6 months, favoring the checkpoint blocker here. And the checkpoint blockers here are here to stay, actually. This is of September 2019, how frontline they're being combined with VEGF target agent or with other immuno-oncology drugs. And I update this all the time. With Nivolumab here, you can see being combined with ipilimumab. The study is there. The combo is approved with cabozantinib, and more recently, actually, with cabozantinib and ipilimumab. So these were our specific aims. With the first aim and aim 2C, I'm not going to talk about. The first aim is metabolomics, maybe next year when we have more data. And the aim we're going to discuss, my aim in particular, is the predictive value of tumor genetic alteration in patients treated with Nivolumab, with a focus on PBRM1 based on our prior work. Now, if we take a general look at genomic and transcriptomics of response to immune checkpoint blocker, this is complex. So if you look just at the tumor, and it depends, this is a very nice recent article by Ellie Van Allen, my collaborator and good friend here, looking at different, if you want, areas of where the primary location is. In terms of T cell, you can look at infiltration, the tumor cell itself. So this is not just whole exome sequencing and looking at specific genes. These are mutational signature, immunogenic alteration in general, and the microenvironment. We wanted to focus through whole exome and the transcriptome on the chromatin modifier losses here. We started, and this is again, and we have a lot of industry collaborators. A shout out to our BMS colleagues here. We started with a study that I actually led in the past called the 009 study, and we used it at the discovery cohort. This study was the Nivolumab in treated and untreated metastatic RCC with baseline and on therapy fresh biopsies. And we end up with 35 patients in terms of discovery cohort, with some of the patients didn't have tumors or actually, had low tumor purity. And of course, at that time, you have to put every paper into context, despite that this was published a year ago. The focus was mutation load, neoantigen load, with all the data that Ellie Van Allen and other generated in the melanoma. And here, this was not associated with response, but the PBRM1 gene mutated in 40% of all clear cell RCC rose up, and we have able to collaborate with our friends at MSKCC here, Ari Hakimi, somewhere here, as well as Hopkins with Chuck and Moalef and others, and we had a validation cohort here that proved PBRM1 to be associated. I don't want to use the word biomarker, and as it is, this is not a biomarker of response. This is understanding biology better, but association with a higher or better clinical outcome. Then Bill came here to our help looking at cell line in PBAF null, PBAF wild type, as well as we had our RNA-seq data and look at gene set enrichment analysis with hallmark gene set, and we found that patient with the PBRM1 loss of function mutation, so we excluded the missense mutation here, were associated more so with an immune profile here in the cell line with the cytokine receptor interaction, and a human here with hypoxia, but IL-6, JAK, STAT3 signaling. And at the same time, I think Ellie also was at the Broad listening to another talk here where the group from Kai Wischer-Fenning reported on a CRISPR-Cas9 genome scale screen in melanoma that actually implicated members of the PBAF complex, including PBRM1 here, but also ARID2 and BRD7, which are much less mutated in renal cell. This is again in melanoma, implicated the gene in cell sensitization to T-cell mediated actually cytotoxicity here. So both were in science, but still some consideration because we needed a validation and larger study with a control arm. Then this was mainly our aim. Remember here, we do not have a control arm of non-checkpoint inhibitor, so the word predictive has to be used with a lot of caution, and I will not use it. The second thing is what we've done concomitantly and what David McDermott and the team, which I was part of, the Emotion 150, is looking at PBRM1 in totally untreated patient, treated with later on with atezolizumab monotherapy versus sunitinib versus the combination, and found no relationship is frontline. And we validated this in the Javelin Renal 101 that here Paul gonna talk about, where frontline you do not have relationship. But most recently, and the only available second line a trial here is 025. So most recently, we just published this, our PBRM1 alteration as a potential marker for immune checkpoint inhibitor. So we validated our finding. Why? Because we had an arm that had everolimus, and everolimus was not associated with response, with clinical benefit, with PFS or OS, unlike PBRM1. But I still want to make sure that this is statistical significance, the effect is moderate at best, and patient with PBRM1 wild type still can have responses. But again, no difference in the everolimus arm overall. What are the future genomic work? We want to complete the whole exome sequencing and the RNA-seq from the trial and integrate, and that's Sabina's part, with IHC and immunofluorescence, and find other biomarker for Nivolumab versus everolimus. And maybe we'll come up with a biomarker for everolimus and make everolimus great again.
Can you hear me? So I'm going to continue now. This is nothing in comparison to Toni, of course. So in this second part of the talk, I'm going to present some of the work that we have done and now utilizing in situ analysis, mostly immunohistochemistry and immunofluorescence. These are much more focused, more hypothesis-driven analysis, but they're important because they really are highly complementary with the genomic studies because they can provide information that genomic studies, at least on archival samples, cannot provide. So we started a few years ago when we established a collaboration with BMS and to get access to pre-treatment samples, tumor samples from a phase 2 trial of Nivolumab in patients with metastatic CCRCC that had previously failed VEGF-targeted therapy. Now, this study, the Checkmate 010 study, was particularly interesting for us because, first of all, it had a long-term follow-up, but even most importantly, in this study, clinical outcome had been collected not only according to the conventional RECIST, but also according to immune-related RECIST criteria. So as all the clinicians in the audience know much better than I do, immune-related RECIST are among new response criteria that have been developed to capture atypical responses that can be seen with the immunotherapy that would be otherwise classified as progressive disease by utilizing conventional criteria. And so atypical immune responses to immune checkpoint inhibitors have been evaluated in some tumor types, especially, I would say, melanoma, but they remain really poorly characterized in clear cell renal cell carcinoma. And so for this reason, the first thing that we decided to do was actually to reclassify patient outcomes from the Checkmate 010 trial according to the immune-related RECIST. And by doing so, as you can see here, the rate of we observed that one of the major findings was the rate of progressive disease according to immune-related RECIST was significantly lower than the rate of progressive disease that you would observe with the conventional RECIST. And this really translated in a significantly longer immune-related PFS compared to the conventional PFS. So overall, these data really seem to indicate that the conventional response criteria underestimate the benefit from immune checkpoint inhibitors in CCRCC. And so this obviously can have important implications for biomarker discovery. And in order to try to address this last point, we decided to go ahead and try to test the very simple hypothesis that candidate biomarkers for Nivolumab would show an improved association with the clinical endpoints that capture the atypical responders compared to the standard clinical endpoints. And so in order to, as a biomarker, we decided to focus on tumor cell PD-L1, mostly because this is obviously a clinically relevant biomarker in some tumor types, but remains controversial in CCRCC. And so when we did this, as shown here, we, in line with our hypothesis, what we found is that tumor cell PD-L1 expression is significantly associated with the immune-related PFS and also associated with the immune-related response rate, but not with conventional PFS and conventional response rate. So basically, PD-L1 expression on tumor cells does better as a potential biomarker when you utilize more meaningful clinical endpoints. And however, as you can appreciate in the IRPFS curves, PD-L1 by itself is certainly not an optimal biomarker because it's not able to identify all the patients that benefit from this therapy. And as mentioned before, there are many patients that are PD-L1 negative that still respond to the therapy. So it was obviously that we needed to go beyond PD-L1, and so we decided to do some focused analysis looking at the microenvironment, and especially, we decided to look at the expression of immune checkpoint on CD8 positive tumor infiltrating cells. And we decided to focus obviously on PD-1 because this is the target of the therapy, but also to focus on TIM3 and LAG3, because as mentioned before, these are a marker of T-cell exhaustion, and they have been related to resistance to anti-PD-1 in cancer. So we did this analysis on archival tissue sections. We developed the multiplex immunofluorescence assays coupled with the spectral imaging. We looked at about 100 patients here, and I don't have the time to go through this analysis, but by utilizing a pretty rigorous statistical approach, we saw the presence of a robust association between the percentage of high of CD8 positive cells that express PD-1 but not TIM3 and LAG3, with both longer immune-related PFS and also higher immune-related responses. And this biomarker here, I mean, this potential biomarker, obviously this is very exploratory, seems to be quite promising, because at least at this optimized cutoff, it seems to discriminate quite well the patients that respond to the therapy. There are no responders in the biomarker negative arm, and all the patients that benefited long-term from these therapies seems to be in the biomarker positive arm. So as a last step, what we did is we decided to combine these new potential biomarker with PD-L1 expression in tumor cells. And by doing this, now we have a potential model that identifies 3 groups of patients that have distinct outcome. So according to this model, patients that have high levels of expression of PD-1, which is the Nivolumab target on the CD8 positive cells, but also express the ligand on the tumor cells, here represented in yellow, are the ones that are most likely to respond to this therapy. Then patients that have high expression of PD-1 on the CD8 positive cells but do not express PD-L1 on the tumor cells seems to have an intermediate chance to respond to the therapy, here in blue. And finally, in green, you have the patients that do not express PD-1 on the T cells and do not express PD-L1 on the tumor cells. And these 2 patients seem really not to respond to the therapy at all. So obviously, this is, as I said, preliminary, but what we are doing is basically trying to confirm these in other clinical trials. So in conclusion, just to reiterate what we have seen and what I've shown you today, is that candidate biomarkers of response to anti-PD-1 therapy show improved response when we utilize clinical endpoints that capture atypical responders. And these data really suggest that immune-related criteria might be optimal for predictive biomarker discovery efforts rather than conventional criteria. And finally, we have a potential biomarker that now we are validating not only in the context of the CheckMate 025 trial, which is a second line, but most importantly in the HCRN GU260 trial that Dr. Atkins is conducting, which is a frontline Nivolumab trial on CCRCC, and we are, hopeful that this will hold up. And I think I'm just gonna stop here and acknowledge all the people that contributed to the work that both Toni and I presented, and obviously we would like to acknowledge the support from the DoD grant.